done, the prostate will have a 15-degree tilt. Okay. So you will always see images with that tilt. You have to avoid that tilt by tilting the pelvis on table. So when you tilt the pelvis on table, the prostate tends to become parallel to the rectum. That's a little tip I'm giving you. You tilt the pelvis, just lift it up, it will tilt, and you get the prostate. You don't have to struggle to do it. So once you do that, you put the probe, just as you would put it for a prostate biopsy, nothing different. Before that, you put the local in the skin, and then you put the needle. This is just rough, I'm telling you. The next is local anesthesia. I give skin anesthesia, and there are differences in practices. I was exposed to both. Some of them do only neurovascular bundle periprosthetic blocks. Some of them go right up to the seminal vesicle and the bladder junction. Okay, and they deposit. So some of them put 7 cc on both sides. The thinking is there is some amount of strangury after IRE, and this probably helps to negate that. All right, I don't have any data on that, sorry, but this is 2 ways of practicing. I practice by just putting it in the neurovascular bundle. That's it, and the skin. That's good enough. Now, if you see this, if you just see this, the black line is the Denonvilliers fascia. Oh gosh, sorry. It's very fast. Okay. The black line is the horizontal level. You can see the rectum and the prostate, the dorsal side of the prostate is extremely, it's parallel to it. That is crucial. And spend some time in prostate positioning. Don't be in a hurry to put needles. I think the successful needle-based procedure is in your first 10 minutes. If you're able to position the probe well, half or more than half of your job is done. Remember that. So don't be in a hurry to hurriedly put the probe inside and put the needles in. Take your time to put the probe in, get your angles properly, and then you can proceed to the next step. Now let's talk about needle, the probe exposure. Now this is the typical probe. You can see the exposures here. And this is what it looks like. So if you see this, there's no exposure here. You move this marker, and if you see it, you can see it, it's around 2, okay? At 2. So, and this much is the exposed. So if you put it at 2, that means 2 centimeter is the exposed surface from which the electricity will be generated, and the lesion should be within that to treat it properly, okay? Now, electrode insertion, this is very, very crucial, very, very crucial. As I said, second step, most important is the electrode insertion. You see the red lines are the electrode insertion, which needs to be parallel. If you see this, this is how it should be. It can't be skewed. It can't be skewed, because if it is being skewed, you won't generate that sort of voltage and energy in electricity in between those 2 volts, between those 2 electrodes, and you are not going to create effective ablation. Okay. If you look at the sagittal view, you look at these needles. Now you must be wondering that IRE needles are put near the periphery. Why this not at the periphery? The reason is I purposely put this image because this is probably not the area of ablation. So this is an apical lesion, if you remember from the diagram. So when you go to the apex, you'll find the needle to be more towards the periphery. But if you go towards the base, the needle will obviously not be towards the periphery. Don't be in a impression that everything has to be in the periphery. It can't. So when you put it in the periphery, try to put it in the periphery, the apex or mid gland, it will always be within the prostate in the mid gland, because the prostate is not rectangular, right? It's not a box. It's elliptical and spherical. Again, here, both are parallel. I'm measuring the distance between the needle. I'm measuring the distance from here to the rectum. Okay. Now, let's go to the third most important point, calculations. I never believed physics would haunt me. I thought physics is left behind, but it has come back to haunt us because of focal therapy. Now, when you look at calculations, I do this. So these are the diagrams I drew for this patient, okay? So this is on typical graph paper. You can draw the diagrams, or you can do it on your iPad also. There are programs which is available to you. So you draw the lesion and you just draw these dots here. What is your plan? And you just put the lines and match for the measurements. Okay, this is important. This is important. These measurements are important. I'll come to that, how it is important. So when you have a plan like this in your mind, you will see that once you put the needles, it reflects on this. Okay. So you put the first to always start with the anterior needles. Okay. Because if you put the posterior needles, then your vision gets hampered and you can't put the anterior. So always start with the anterior needles, then you start with the posterior needles. So here we have put the anterior needles. And if you see, there are two types of configuration, which is academic, but it can vary from patient to patient. If you see this, this is a box type and a box and triangle type. And this is again two boxes type to cover the lesion. So 6 electrodes. The question asked to me, what is the minimum electrode needed? It should be 4. It cannot be 3. The reason is because of this. If you put 4 electrodes, you see this, the yellow line is the tumor and the coverage is maximum. So you have to get maximum margins for prostate, minimum 4 tumors, 4 electrodes are needed. So if you see this, 4 is covering, or 5 is covering more than 4, covering more than 3. If you go at the needles, the lesion should be between the needles. So principle is the Ohm's law, okay? V equal IRs, but the resistance remains constant because the prostate depends on how the prostate architecture is. If the amplitude of the if the amplitude is very high, which you can see on the graph, you drop the vision, you drop the voltage by 10%. If the amplitude is low, increase the voltage by 10%. Resistance remains constant. Okay. The aim is to electroporate irreversibly and not to ablate or electroporate reversibly. Okay. Now this is important. This I'll skip. This is not important. Now what is important is the next thing here. So if you look at the exposed part, this is the exposed part. This is the electric field, but beyond it also we have 5 millimeter. So when you're taking the total length, total exposure, if the total exposure is 2 millimeter, you take 1 millimeter of exposure and 0.5 on both sides. That completes 2 millimeter. That is important. You can't take 2 millimeter of exposure because you're adding 1 millimeter exposure more. Of course, this is in part taking into consideration the margins. That's where the calculation is important. And most of the problems happen here because we don't consider the electric field after the electrodes. Prior to treatment, you insert the catheter, or you may or may not, depends where the lesion is. You alert the anesthetist, the needles are in, and you need to deep relax the patient. Very important, otherwise you start jumping on the bed, that's a problem. So you should give anesthetist adequate time to deeply relax the patient, and then you start the ablation. Now, first run of 10, you first see how the patient is and the prostate is behaving and responding. You look at, if you look at this, I usually keep a target of 1500 to 2500. Maximum 3000 I can extend, but not beyond that, not below 1500, because it's going into reversible electroporation if it is low. If it is high, it goes into ablation or thermal energy, which we don't want. The spacing, if you see this, the spacing between two is around, they recommend 1.5 to 2.5, but I keep it between 1.8 to 2 centimeter. That is enough spacing between two electrodes. All right. And once that is done, these two are the most important. And you can see the. So once you see this in 10, you can see it is below 30. So 20 to 40 or maximum 50, you can over 40 is the cutoff, 35 to 40. If it's between that, it is good response. So you stop. You will always get this decreasing curve because the prostate is resisting it. You'll have the resistance factor coming in. Once you're happy with the first 10 runs, you go to the next 90. You see there are some changes I've done here. I pushed this up to 240 and I'm getting adequate here. Okay. Once you do that, you run 90. And that's how you go. Now this you can ignore because that is all resistance happening. But you can see changes happening on the, these are a sort of changes which happen. You need to visualize the needles every time. Keep shifting from axial to sagittal view. See if the needle has moved. If it has moved, position it back. See if the needle has gone out. It can happen because the patient will give some jerks in his legs because the pelvic muscle is not completely relaxed. You'll have some pelvic contractions happening. You need to be mindful the needles can move. Pelvic contractions, watch it. Waterfall effect. This is sort of a thermal effect which happens around the prostate, around the needles, which is perfectly fine, but need to watch that. That is what it is showing, that the effect is happening in the prostate. Watch the sphincter. So you can see that there is pelvic contractions, and then you see the needle. Then if after that you remove the needles, put perineal pressure, very, very important. You put catheterize, bladder wash, important, and no heparin, please. All right, that's very important. I don't give heparin after this. And day case discharge, TWAC at 7 days, a Zumol of catheter of 7 days, MRI 10 to 15 days. I do it. You start of your focal program, you can do it maximum by 1 month, but not beyond it, which doesn't help. But PSA every 3 months, MRI at 1 year, and then depending on the PSA trajectory, after 1 year, it is PSA every 6 months, and the MRI would be every alternate years. So this is what happened 10 weeks. You can see the coverage here of the same lesion here, okay? And this is what was at 1 year. The prostate has shrunk down. Done. There's nothing much to say, actually. Yeah, just know your MRI well, detailed counseling, good margins. And whenever you find that the two needle distances are more, just neglect those needles, okay? Don't have to ablate all needles. Just see what the distance is and neglect it, okay? Thank you. Any questions? I'm happy to answer.
So, Dr. Santosh, it's a very highly technical job. So, what is the learning curve in this?
I think UCLA says 15 cases. That's what was it for my.
And how much is the failure or the complication rates?
I think it is, the fistula rate is, we haven't got a fistula as far as we are working on the registry which has started. I have not seen any. But if you talk about the infill recurrence, it is similar, more or less similar to the HIFU data. We haven't seen any deviation from that so far, even though it's a different biology and different type of energy given. So it's a needle-based thing. It's intense. It's skill intense. But if you are doing transperineal prostate biopsy, that's the reason why I asked this question to Dr. Santoshi, because if you're going to do this, you need a brachytherapy grid. So when you're doing biopsy with brachytherapy grid, you already your mind is getting tuned to putting the needles. You have to think about that if you want to buy the biopsy.
Thank you.
Thank you so much.
Thank you for such an enlightening session, sir. We now move forward with the last speaker of this session. I kindly invite Dr. Himesh Ramesh Chandra Gandhi, Consultant Uro-Oncologist, Director of Robotic Surgery, Robotic Uro-Oncosurgeon, Ruby Hall Clinic, Pune, to deliver a talk on Focal One.
I'll try to keep it short. So this is the first lecture, I think, of Focal One in India, which we are giving now. And this is the machine, what something it looks like. So pillars of the focal therapy are very simple. It's to plan, ablate, and then validate. This is the transrectal probe, which has a ultrasound transducer, which is 7.5 megahertz. And there are multiple rings around this transducer. There are 16 rings which generate 8 focal points, and the frequency is 3 megahertz. This is the principle. All rings converge at some focal point, and energy is generated at this area. So this is actually what is happening. So when we select an area for focal therapy, these are the multiple points which are generated along the prostate, and each has an ellipse of approximately 5 mm in length and 1.7 mm in diameter. So normally the patient is positioned in a lateral Sims position, and we can use a general anesthesia or a spinal anesthesia. This is a separate special pillow which is provided by the company so that the patient can rest properly and there is no wobbling of the patient in the lateral position. We don't use nitrous oxide use is not recommended, obviously, because of the cavitation effects which happens when you use a HIFU. Catheter is placed inside the bladder so that we can visualize the prostate very easily. If the patient has TURP, try to put the catheter inside the bladder. The balloon should not come in the prostatic fossa, otherwise it will obscure the imaging of the prostate. So this is the catheter in the prostatic fossa, which we need to put it back inside the bladder so that it doesn't obscure the vision. So the position is something like this. The patient needs to be at the edge of the table. The focal one machine comes 90 degrees to the patient's bottom, and there is a 10-degree tilt of the patient so that the alignment of the rectum comes exactly in line of the probe. So this is the insertion of the probe, and there is a this is basically tester where we need to which measures whether the patient is moving or not. So normally before we insert the probe, either a 2-finger or a 3-finger dilatation is required so that the probe can go in easily. We sometimes use the dilators. And once the system is inside, we have to see whether how is the vision of the probe captured of the prostate. So this is the probe insertion. The probe has some attachments, some buttons which we can use to maneuver the probe so that the visualization of the prostate is perfect. These are some of the buttons which can help you in alignment of the probe. Now the important thing is the center image where the probe has to be exactly at the center so that it is equidistant from the rectal wall. So this is the center what we have developed right now for the focal one. So this is how the system looked like, and this is the condom which we attach, and it's a cooling liquid. And once the dilatation is done, we gradually insert the probe inside the rectum, and then we inflate the balloon, the condom, so that the prostate becomes at the center of the probe. So these are all the attachments what we use, and we then adjust the fluid inside accordingly so that it becomes in the center of the probe. So then starts the image acquisition. So once the probe is inside, then it's all now. You don't need to use your hand at all, and you have to just start the application. So this is this is the MRI images which we can contour the prostate and the region of interest before we have acquire the ultrasound image. So this is a desktop which is called a high fusion desktop software. One day prior you can do it all the charting, and you can make the boundary of the prostate, especially, and also you can have the region of interest. So this is the region of interest which I am drawing where the tumor is present, and we can have a 3D dimension of the tumor of the and along the prostate contour also. So once this is done, what is the correct orientation? The rectal should be parallel. It should not have an angulation or something like that. It should be in a straight line. This suggests that when we acquire the ultrasound image, the uniformity of the acquisition is maintained. So once the ultrasound image is acquired, the MRI plus ultrasound images are fused. So the pathway follows something like this. We can also use a PSMA PET scan image, and we can fuse with the ultrasound image. So this is the fusion, what is happening here. This is the MRI image. This is above is the ultrasound image, and when you see the right side picture, both can be fused in the same images. So once the fusion is done, then you have to define what is the apex, what is the base, and what is the area of interest. Now, a lot of consideration has been happening regarding the rectal wall detection. So the orange line is the rectal wall detection. It is a software driven, and our goal is that we have adequate liquid so that the orange line falls on the rectum. How to confirm that, okay, the treatment is happening properly? It is through the cavitation effect, what is happening inside the prostate. What is the ideal margin? We normally select the index lesion, and we trying to keep a 9 mm margin on the images so that we can have a proper coverage of the lesion. Post treatment, the probe has an inbuilt contrast and ultrasound so that we can inject the VisiPack, and we can have the dark halo inside the treated zone. This confirms that the treatment has been successful, the delivery has been okay. So this is the patient I would discuss, that he has a 3+4, 3 out of 4 positive, a bit of apex mid lesion, PSA 7.7, and sexually active. So we gave the option of HIFU, and this is how the real-time treatment looks like. So data entry is important. We have the data entry. Then we have an ultrasound acquisition of the images. So this is the ultrasound we have inserted inside, and we are now acquiring and readjusting the orange line so that it exactly falls on the rectal wall. So this is the seminal vesicle, and we have a clean sweep. This is all done with the mouse, so that now you don't need to touch the probe, and it's all robotized. So here you can see that the orange rectal wall detection is happening. And yeah, now the ultrasound is sweeping. So this is the acquisition which will be eventually fused on the MRI images. So this is the ultrasound prostate volume acquisition. You can adjust the markings in sagittal and axial section, and you can have the exact volume of the ultrasound. So MRI volume and the ultrasound volume has to match. If MRI shows 65 grams, it has to be 65 grams on the ultrasound. 1 or 2 grams here and there is okay, but it has to be there. So once this is done, once the fusion has been done, I'll just skip through it. So this is the ROI which we are intended to treat, and we have to mark the upper limit, lower limit, and then we have to start the firing. So once this is done, this is actually the real-time firing which will happen. Now, if you feel that there are some additional layers also you need to do, you can use this button and you can increase the number of slides. So now this is the correct orientation we are going to treat. This is more of an apex lesion. So we have chart out the lesion, and this green dot should turn red once the energy is delivered. So this is the perfect config. We can do a real-time readjustment of the boundaries so that we can include more of the lesions if we feel that the contouring was not accurate. So this is how we can increase the field of treatment while we are doing the things. And once this contouring is done, we can start the firing. So this is the firing which is happening. Now you have to see that this is all robotized movement. There is no manual control, and the adjustment of the probe is happening all with the help of the software-driven mechanism. So there is no human intervention. But suppose I feel that the lesion is out of the field, I can pause the treatment, I can reorient the boundaries, and I can restart it. So now this is the exact thing what is happening. And what here we look for is the cavitation, what is happening. So you can see the nice bubbling of the tissue happening, and this is the cavitation which is happening. So this is I have fast forwarded it, it doesn't happen so fast. But this is the cavitation what we are looking, and you can reorient the region of interest. So within 45-50 minutes, easily you can treat around 25-30 cc of the prostate. So this is what the cavitation we are eyeing for. Once the treatment is over, then you can switch on the contrast enhanced ultrasound mode, and you can see the dark area happening, the loss of vascularity happening at the lower bottom picture. So this signifies that we have delivered the treatment properly, and it has now ablated completely. So with this, I would like to thank you for this opportunity. And if you have any questions, I'll be ready to answer it.
No, excellent talk, Himesh. I just want to know that out of percentage of patients in whom you think that this is the right treatment, you guide them, you suggest them, and how many of them take it up?
So the best thing about this is that this can be repeated. So if I find a patient of a unifocal disease, 3+4, patient not very actively involved for willing for surgery or radiation, this is one of the treatment what we are right now offering. Till now, we have done 5 cases of robotic HIFU. All are sexually active males between the age of 55-60, and all the 3 options were given, and they volunteered for this treatment because being minimally invasive. And those patients have been kept on follow-up. So let's see how the response is.
How much is the follow-up so far in months?
Right now, we have 6 months data.
For the next talk, I would like to call upon Dr. H.S. Bhatyal, BLK Max Super Specialty Hospital, Delhi, Dr. Anjali Pauja, Radiation Oncology, RGCI, Delhi, Dr. Nishant Gurnani, Consultant Urology, AIMS, Delhi. Next talk will be on evidence-based update, evidence update on focal therapy, summary of key focal therapy trials in 2024-25 by Dr. Rahul Jena, Consultant Uro-Oncologist and Robotic Surgeon, Bhubaneswar. He'll be joining us virtually.
Good afternoon, Dr.
Can I
Rahul.
start?
Please, yes, you can please start.
Good afternoon, sir. Right. I'm sorry I could not be there in person. I'll just quickly run through because Ashish has been messaging me in the background to finish it quickly. I'll mainly be talking about, I'm sure all of these trials, sorry, I can't seem to, okay. So I'm sure all of these trials have been discussed at some point of time in the program today. So I'll be mainly talking about the HIFI trial, the PRESERVE trial, and the FARP trial. The HIFI trial was on whole gland HIFU, and it's basically a non-randomized prospective non-inferiority trial where it was carried out in France, protocol made in 2014. Approximately 3,300 patients were included in the final analysis, mostly consisting of low to intermediate risk prostate cancer. And for all patients less than 69 years of age, the radical prostatectomy was done, and those above 70, they had an option of choosing between radical prostatectomy and focal therapy. The focal therapy involved at least 70% of the prostate volume, and radical prostatectomy was according to the choice of the surgeon. The main primary outcome was to demonstrate a non-inferiority of focal therapy as compared to radical prostatectomy, and there were 6 monthly follow-ups up to 30 months. Failure was defined as biochemical recurrence for radical prostatectomy, and for focal therapy, it was demonstrating cancer at defined points in biopsies. In addition, they also had patient-reported outcome measures. The results, the primary endpoint was salvage treatment-free survival, and the secondary endpoints were metastasis-free survival, prostate cancer-specific survival, overall survival, and safety. So a total of 1,967 patients received focal therapy, and 1,361 patients had a radical prostatectomy. The primary endpoint at the end of 30 months, which was the need for salvage treatment, that showed that the focal therapy was not inferior to radical prostatectomy. It was around 90% in the focal therapy arm versus 86% in the radical prostatectomy arm. The secondary endpoints were that the PSA nadir was reached at about 0.25 for the focal therapy versus 0.01 versus radical prostatectomy. The radical prostatectomy arm also did have about a 26% margin positivity rate. And in the focal therapy arm, on follow-up, 289 patients were deemed to be fit for biopsy, of which 243 had a positive biopsy. There were no prostate cancer-specific deaths or metastasis in either of these groups. The functional outcomes was that the deterioration in the 12-month ICS score was more in the radical prostatectomy arm compared to the HIFU arm, and the drop in median scores for sexual functions questionnaires was also more in radical prostatectomy as compared to focal therapy across all age groups. And this keeping in mind that the patients in the HIFU group were already older to start with. So even after that, the drop in sexual function was less. So take-home points from this trial was that HIFU had non-inferior oncological outcomes for localized intermediate risk disease, and the side effect profile was also significantly lower. Now, what we need to think about is whether the salvage therapy free survival is a valid endpoint, because there was a difference of almost 10 years median age between the two arms, and also the use of ADT on recurrence was about 10 times more in the HIFU arm. So we move on to the next trial, which is the PRESERVE trial. This is on IRE using the NanoKnife. It was a prospective study, 17 centers in the United States, and carried out from 2022 to 2023 with 12 months follow-up. This included patients of, again, mainly low and intermediate risk. The endpoints were, the primary endpoint was what was the proportion of patients who had an in-field negative biopsy at 12 months time on follow-up, any positive cancer, including Gleason grade 1. And the secondary effectiveness endpoint were how many negative biopsies were there at 12 months follow-up, including only the clinically significant prostate cancer. By this, it means that some amount of Gleason grade 1, even though present on biopsy, was excluded from analysis. The additional endpoints were PSA kinetics, volume changes, and need for secondary and adjuvant treatment. So 121 patients were treated with IRE. The negative in-field biopsy rate at 12 months was about 71%. And the secondary endpoint, whereby some amount of Gleason grade 1 cancer was allowed, was 84%. The time to median PSA was 3.5 months, and the median reduction at about 6 months was 68%. 40 of these patients had an out-of-field prostate cancer recurrence at about 12 months, and 50% of them were Gleason grade 1. Of those patients who had pre-existing untreated Gleason grade cancer out of field at baseline, at 12 months, 7 of them had persistent Gleason grade 1, and 2 of them underwent reclassification, and 8 of them did not demonstrate any cancer. Now, these results whereby there was cancer to start with at baseline out of field and there was no cancer at 12 months follow-up could be attributed to variability in MP-MRI interpretation, development of de novo prostate cancer, sampling errors during the baseline biopsy. And also if the ablation procedure itself has altered the architecture of the gland and there are anatomic changes now. The functional outcomes all dipped down at about 1 month's time. This was the questionnaire for the lower urinary tract symptoms, and more or less came up to baseline at on subsequent follow-up till about 12 months. The sexual functions also showed a dip at about 1 month's follow-up and gradually improved to about 80% of baseline across all domains. And about approximately 80% of men had erections sufficient for penetration. So the key take-home points from this trial were that there are promising short-term oncological outcomes, and a focal ablation instead of whole gland ablation improves these short-term outcomes. There were a low number of significant complications, and also that IRE can be safely performed for tumors in any location of the prostate. The third trial was presented as an abstract in Las Vegas AUA, and this was done to compare treatment failure at 3 years in unilateral clinically significant prostate cancer. So there was very little of low-risk prostate cancer in this trial. 213 patients, 107 and 106 in each arm. The primary outcome was rate of treatment failure, which was defined as requirement of radical prostatectomy or RT due to high-risk prostate cancer in the focal therapy group, and biochemical recurrence in the radical prostatectomy group. And all of these patients, the focal therapy group, had an MRI and systemic biopsies at 1 and 3 years. The proportion of treatment failure was that it was 6.5% in the focal therapy group and 8.5% after radical prostatectomy. So there was a difference of about 2% in both the treatment arms. Now, this is a meta-analysis which has compared 14 studies, all of the studies that have been published till date, and has about 4,300 and has about 8,600 patients, equal number in the radical prostatectomy and the HIFU arms, but mainly low-risk disease and some intermediate risk patients. So these diagrams mainly show that the salvage therapy-free survival is more in favor of the radical prostatectomy arm. The biochemical recurrence is also more in favor of the radical prostatectomy arm, and the overall survival also appears to favor the radical prostatectomy arm. The take-home points are that from this meta-analysis is that there are comparable short-term oncological outcomes, except the salvage therapy-free survival, but the functional outcomes are definitely better. So to answer the question, based on these trials, is focal therapy ready for prime time? It's difficult to say because, most of these trials were started in 2014, 15, 16, 17, when the low risk disease was still something which was treated. Now the guidelines have changed. Now guidelines strongly recommend active surveillance for all low risk disease. And most of these trials, the majority of patients in these trials had low risk disease. It's difficult to say in the absence of proper randomized controlled trials, how focal therapy would affect the patients of high risk and intermediate risk who we treat mainly in the contemporary times. And where does focal therapy fit into the treatment pathway? Because there is a learning curve and you do need good radiologists for proper interpretation of MRI, not just at baseline, but also to monitor the treatment and to decide when you need to do a biopsy. And you also need a dedicated program. So this question remains unanswered for me. Thank you.
Thank you, Rahul, for a very crisp and analysis of all these trials. But we all know that all these focal therapies are still in infancy. Nothing has been established so far so well as compared to radical prostatectomy. Am I right?
Yes, sir. Thank you. Yes, sir. Couldn't have said it better myself. Hello?
I think the limitation also remains on part of the pathologist in interpreting a recurrence and changes after focal therapy.
Yeah.
Not just a
I personally feel that other than the functional outcome in these focal therapies, as compared to radical prostatectomy, there is hardly anything to differentiate. We get as the outcome in radical prostatectomy is still to be compared with all these focal therapies.
As we reach the final
Eventually, okay, sorry. I was just going to say that eventually focal therapy is going to make more strides and we are going to have more of it. It's just that at this point, it's difficult to say if it's ready for the prime time. Yeah.
Very well said, Rahul. I have been into these things for the last about 30 years. Many things have come and gone, and we have to just wait and watch as to which one will strike the balance.
Yes, sir. Yes, sir.
As we reach the
That's
final
all from my
session,
side. Thank you.
Thank you, Rahul. Thank you very much.
as we reach the final session of the GU Focal Summit 2026, we thank you all for your active participation throughout the summit. The last of our event for this summit is the debate. The topic of the debate is radio recurrent prostate cancer, salvage focal therapy versus re-eradication versus salvage prostatectomy. For this, I would love to invite our first speaker, Dr. Jiten Jaipuria, Consultant Uro-Oncology and Robotic Surgery, Portsmouth University Hospitals NHS Trust Fellowship, Focal Therapy, Prostate, Imperial College, London, UK. And the topic for sir is salvage focal therapy.
Dr. Jiten, please stick to the time limit.
For that. I thought I would be called later, but anyways, let's start. So I don't have any conflict of interest. The aim is we're trying to arrive at a consensus here because modalities are often complementary and not competitive. And we are here to understand nuances. There is a role for every modality. We are here to solve problems, not create new ones. Prostate cancer, as we all know, 1 in 8 men is second most common cancer in India already in many urban registries. It's most common cancer in men in UK now. Radiation is 2 times more common than surgery when it comes to treatment options. And when you look at how much it succeeds, the historical data has not been very good. If you look, it depends on the T stage. If you're treating a T3 with a radiotherapy, if you actually take those prostates out, 58% still have residual disease. Even in modern era with newer protocols, it's still 29%. So it hasn't really, again, it's not, we need treatment for a lot of these patients again, and treating local failure is important. So if we because it's a surgical talk, I also need to emphasize when we rebiopsy these patients, please do not biopsy target only. You still need perilesional sampling. This has been proven in forecast trial because 3 out of 5 cancers are still outside what the MRI will show you. Now coming to salvage options and understanding nuances as to what to choose. Broadly, salvage options are of 2 types. Treat the whole prostate again, whether it's surgery or re-irradiate the whole thing, or treat only the cancer-bearing area. Now, focal therapy can be used to deliver both. You can treat the whole gland via focal therapy, or you can treat the cancer-bearing area only. When it comes to salvage options, focal therapy, there is no strict age cutoff. While for surgical options, you really don't want to operate on an elderly guy. Above 75, you won't be offering them. Life expectancy obviously should be not less than 5 years. Again, focal therapy, you can go performance status 1, performance status 2. Surgery, you may not really want to operate on a guy with performance status 2. And if you look at the actual data for radical prostatectomy, EAU has a consensus statement on it, which has been after thousands of cases. So the good results of salvage prostatectomy are only those who have a favorable sort of a recurrence. So recurrence has to be less than equal to T2B, Gleason score less than equal to 7, and preoperative PSA less than 10. I can tell you most patients actually do not fall in this criteria. So majority of patients who actually recur, who do need treatment, are not in this good risk category. And when you operate on the bad risk category ones, the outcomes are not good. So historically, the fistula rate, rectal fistula rate was 10%, erectile dysfunction rate was 100%, incontinence rate was 30%. That was the data after salvage prostatectomy. In 2023, with modern better case selection and techniques, we still have 20% people wearing pads at the end of 1 year, and 50% will recur in the next 5 years. So this is the success rate we are looking at, that 50% will recur, 20% will wear pads even if we remove the prostate. What about HIFU and cryo? You can do this in T3A as well. While salvage prostatectomy in T3A, T3B, you won't be doing it. The results are bad, it quickly comes back. And you have now nuances. You can choose cryotherapy for anterior lesions, HIFU for posterior recurrences. And recurrences after radiotherapy, when it recurs locally, usually it is a well-defined recurrence because the cells in other areas are practically dead. So you don't need to really treat the whole prostate again. The area which has failed is usually the area that needs treating. So re-irradiating the whole thing, treating the whole thing again, it's kind of an overdue. So if you look at even whole gland cryotherapy and whole gland HIFU outcomes, at 10 years, 69%. So in Imperial, we counsel patients, 2 out of 3 men after a salvage focal treatment, after radiation, will not need further treatment 5 to 10 years down the line. So rectal fistula rate, 1 in 300. There have been not a single grade 3 complication recorded in the registry since last 700 cases because our experience has grown and only senior people are doing it. When it comes to re-irradiating, you do not want to re-irradiate anyone within the first 2-year window of his previous radiation. If somebody has bad pre-existing LUTs, please do not re-irradiate them because the LUTs really, really worsen. You need to give more adjuncts to them in terms of a TURP or something. So again, those are areas where you focal therapy can pitch in because focal therapy does not affect the bladder and you can manage it in a standard fashion. While with radiation, there are enough studies now, the compliance of the bladder changes. So treatment-related nuances, if you're planning to re-irradiate them, you use HDR brachy, not LDR brachy, or you re-irradiate them with SABR. They will give ADT, which focal therapy will not need. So that's also a plus point towards focal therapy. So the grade 3 toxicity rate after re-irradiation, they can go up to 6.5%. While like I told you, after salvage focal therapy, we have not seen a grade 3 event in last 700 cases. So theoretical advantages are lower toxicity. And as we pick up recurrences later, we can afford to treat just part of the prostate. And that really, really lowers the complication. So if you look at now focal salvage data, which is different from whole gland salvage data, there no grade 3 event has happened throughout the last 2000 plus cases, last 700 cases, none. And the recurrence rates are similar. 5 years down the line, 50% patients are doing well. 2/3 actually, if it is a really well chosen case. So in the last slide, this is how we choose. So I do prostatectomies as well. So I would choose salvage RP for a good kind of recurrence. If he's a young patient who has a T2 sort of a recurrence, sometimes seminal vesicle recurrences are great for salvage prostatectomy because you can't treat seminal vesicles well with focal therapeutic approach unless it's just the base of SV involvement. So yeah, true. Salvage RP is the only modality that can claim to cure. In focal recurrences, if salvage focal therapy, we don't promise cure, although I think we have cured few, but that is just because we don't have 10-year data yet. And the other problem with salvage prostatectomy is there are not enough surgeons to do it. You really need an experienced surgeons. So I would do salvage RALF for few good young men with favorable characteristics. This is just one example. For example, this guy had a cancer recurrence in the left anterior sector, and all we did was we did a cryotherapy. 1 year down the line, it's a nice cavity there. So if it's a T4 sort of a recurrence, again, surgery is not an option. That's where I would re-irradiate, because T4, all those sorts of recurrence, you can't put a knife to them. So there is a nuance. Every modality has a role, and I think I just clarified where we stand. Thank you.
Thank you for your valuable insights, sir. Now I kindly invite Dr. Susuvan Banerjee, Senior Consultant, Radiation Oncology, Medanta, the Medicity, Gurugram, to deliver his talk on re-irradiation.
We have Dr. Suzovan's presentation, please. Thank you.
So thank you organizers for this opportunity. So I will be very short because I understand. So this is a debate topic and those are my urology friends actually, but I think they have done a disservice to their subject already. You can see Hugh Hampton, the father of urology, he started prostatectomy, but he then shifted to brachytherapy. These are old handwriting drawings. He started doing brachytherapy and he has done more than 500 brachytherapies. The father of American neurosurgery, oncosurgery, and his textbook of urology devotes more time to radium therapy than to radical prostatectomy. So try to understand brachytherapy is in your heart actually. And come to the other side, Henry Becquerel, he is the father of radioactivity, and you'll be happy to know my birthday and his birthday coincides. But I have been true to my faith, and I am serving my discipline well. Okay, so I'm not going to detail because want of time. So pardon me, but this is my aim. As a radiation oncologist, I want to put it in pace. But the main problem is once you send the patient, the patient says, सर्जन ने बोला है कि रेडिएशन होगा तो हमारे पास दोबारा मत आना और कोई ऑप्शन नहीं बचेगा. So that is my problem. So that's why I miss my patient. You actually cut them. So, but I know you are Superman and you can actually do it. You can do a surgery in a post-radiation case. And even I know I will be happy to lose from the surgeons if they make me convinced that their salvage treatment is better than mine. So I'll be more than happy. Now, when I got this topic, look, I am not really a great academician, but I first thought कि focal therapies भाई कौन है ये, कहाँ से आते ये लोग? I thought like this. And now I came to know that you have traveled come 30 years and you are moving from here and there, and every time you are finding a newer modality. And I was wondering to suggest you to put magnet therapy or acupuncture also in your kitty so that you can have more papers and more studies. Now, this is your total status. In the primary setting, you have actually nothing to prove. And I came to know even in low, medium risk, no treatment is also needed. You all know that. So let us give us a break. Actually, I do not know that you want to really, the urologists really need to learn this or not. Now, this is my status. I am on the horse and you are on the boat, and I am fighting with so many people. All the modalities together, radiation is fighting, but it's not political, right? So about radiotherapy techniques, we have a lot of techniques: brachytherapy, HDR, LDR. Then I have this SBRT. Brachytherapy is time-tested, proven, already said by preceding speaker also. HDR is most best nowadays. It has almost replaced LDR. And then MR-assisted brachytherapy, proton radiation. I am not going to the details, but those are newer kids in the block, and they can actually get much better result than what even today's things are happening. So you see, in radiation, we have a complete portfolio. We treat the whole gland, we treat the half of the gland, and we also treat focal treatment. So if you say focal treatment, we can also treat radiation by focal treatment. And the same reasoning stands that you are actually using for yourself. So I am again not going to lot of studies because there are all are level 5 or rather level 6 evidences and there is no point of collating them. But all the good guidelines actually give equal weightage to all the techniques, and they have said it's at the end of the day decision of the physician and the patient discussion. But they have all given well place to radiation oncology in this. And those are just, I will show 2 only systematic reviews. Those are all from those level 5 evidences. So ultimately it is also level 5, the systematic evidence. The master is a highly quoted. I think you have deliberately skipped it, but it has shown that SBRT, HDR and LDR on the modalities, HDR gives best 5 years recurrence-free survival. At the same time, the toxicity, the amount of toxicity is really less. Leave aside surgical techniques, even with this local treatment, the is really good. You can go through the paper if you want, but it is a good paper. Similarly, another just published in 2025 only, it also says, and if I have plotted the authors actually, of the 7 or 8 authors, 7 are surgeons and 1 is only radiation oncologist. And see the concluding statement. Currently, prostate salvage radiation through brachytherapy or EBRT represents the modality providing the best balance between efficacy, safety. Due to the low level of evidence, a strong connection, the choice. So this unfortunately is on the part of the radiation oncologist that we have not been able to gather this evidence. That is our fallacy, but radiation undoubtedly stands tall. So, but now why are we fighting? The another question is, so actually only 2% of the patient received any local salvage treatment after a recurrence. So let us not fight. We have enough for everyone, as Mahatma Gandhi said, we have enough for everyone in this world, but there is not enough for 1% greed. So it's not about greed, that's our passion. So let us all collect together to start something that we given the patient a cafeteria of choices, and the patient, let the patient choose what is the treatment should be. Okay, so I am not again going to tell. So this is myself, you can see my picture, and I'm happy to tell you, I have done my HDR brachytherapy, is a salvage recurrence case. SBRT, you have a cyber knife, you can see this real-time tracking we do, and in our department, it's all the Medanta picture, and I have also assisted on electroporation. Already you can see I was standing there, I was giving logistic support to the IR people, the intervention people did in my OT. Actually, this is my OT. You can see the CR in the back there. And I give them my HDR template because they need the HDR template to do electroporation. So I was happy to see it was an interesting case for me. But I am yet to see the radical postoperative setting. So I have kept the area vacant. Dr. Puneet offered me to see one, but I will go and see in some days. So now the last slide almost. So, this is the medal of American Association of Radiation Oncologists. And you see the pictures. They have radiation oncology signs on this. They have the trocar, they have this radiation sign, they have alpha, beta, gamma. So radiation and urologists are actually friends. And this person made it sure that there is a technique of doing LDR. So brachytherapy has come through the urologist. And it's time that you understand and you come back to us, because you have left the true path and have gone for other paths. I mean, if you have left surgery and you're trying to do techniques, they're actually most technical than being a doctor. And symbiosis, symbols of radioactivity as well as seeds are planted. So I think we should work together. I should learn from you. I was learning electroporation, and we have learned from you for centuries. And I want that you should also approach us. Let us work together for a betterment of the patient so that the patient gets a treatment. And thank you all for your kind attention. Thank you.
Amazing, sir. लगता है आपकी टॉक के बाद सब जग चुके हैं. Thank you so much, sir.
Thank you for such an engaging and thought-provoking talk, sir. Now we move on to the next topic, salvage prostatectomy. For this, I would like to invite Dr. Pankaj Panwar, Additional Director, Department of Urology, Fortis, Okhla.
Thank you so much. It's the end of the day. I will be very short. And I think most of the talk has already cleared my path. There are a group of patients who will definitely need surgery, and there's no denial in that. So I'll begin. So re-irradiation repeats the past, as is clearly, and focal therapy narrows the view. Surgery changes the outcome. If cure is the goal, gas work is not a strategy. Only one salvage option removes the cancer, stages the disease, and plans the future, and that is surgery. Salvage prostatectomy is not aggressive. It is a definitive option. So why salvage prostatectomy? Because it ensures there is a complete removal of the recurrent disease. There is a definitive pathological staging, durable oncologic control, clear roadmap for further therapy, and best chance of long-term ADT avoidance. So data shows clearly 1/3 of the locally advanced prostate cancer, they receive radiotherapy or focal treatment. And good cancer survival rates are there, but up to 60% recurrence rate at 5 to 10 years in these group of patients. Salvage radiotherapy, older data showed higher complication, it's a radical prostatectomy, which has higher incontinence and complication. But now we have a robotic platform which has greatly improved these outcomes. So this is a very great study, and I think this is a high volume multicentric data by the European Association of Urology. And we can see there were 397 patients who underwent salvage radical prostatectomy from 2008 to 2023. And they were all divided into 3 groups. Of course, some received the radiotherapy, some received whole gland ablation and focal treatment. And the complication rate was only 1% in intraoperative complication, and less than 2% had greater than 3 complications after the surgery. And 5-year biochemical recurrence rate were only 35% in the surgery group, and also 45% for the focal gland ablation. And 3-year cumulative incident continence was 67%. And overall survival rates at 5 years were excellent in all the groups. So these are the other studies which you can see the oncological outcomes is pretty good in the surgery settings. And 5-year biochemical survival 48 to 59%. And overall survival and cancer-free survival were excellent after the surgery in all of these studies. So if you see the overall 5-year biochemical survival, most of the studies is 48 to 59%, and cancer-free survival 89 to 98%, and meaningful proportion they achieve long-term disease control after the surgery. So the preserving quality of life is a great role in this setting of the patient. So lower likelihood of early lifelong ADT is what the surgery offers. There are longer ADT-free intervals, and there are improved long-term quality of life. But about the morbidity, yes, there are functional risks after surgery, but outcomes have significantly improved. Robotic surgery plus careful selection of the patient is the key. So salvage prostatectomy, however, is favored when there is a multifocal or whole gland recurrence. There is a prior high dose radiation which limits the re-irradiation, and need for a definitive pathology and young fit patient seeking a curative option. So to conclude, it is best for the localized biopsy-proven recurrence, which is with the reasonable life expectancy more than 10 years, fit patients in the experience centers, and it offers a definitive cure potential, pathology-driven precision medicine, and clear multimodal pathway. So salvage prostatectomy should not be judged by its complication rate in unselected patients, but by its curative potential in carefully chosen one. I'm just going to run a quick video to show how the robotic platform have changed. And this is after the radiotherapy 5 years, and you can see how dense the posterior plane is. And that's how we begin, always finding the rectum and posterior planes to begin with, that they are all right. Now this is the apical area of the prostate. And there's always a lot of blunt dissections. A little bit of bleeding is expected, but the planes do open up. And the structure preservation can be very, very well done with this robotic technology. And this bladder neck is always an issue. Of course, there is a good chance that you will open up a slightly wider bladder neck in this patient, because some of these have TURP as well during the course of their treatment. But however, you can always reconstruct the bladder neck. And with a good blunt dissection, and you can get the seminal vesicles and everything dissected very well. So this is the most critical part of the surgery, separating it from the rectum. But as you can see, even this plane can be very easily, tackled with this robotic nice vision and good instrument control and experienced surgeon. And hence you can preserve a very good urethral length, which is very important for the continence, and that plane usually you find it easy to manage. And this is a bladder neck reconstruction. That's the anastomosis. So thank you.
So as we come to the conclusion of today's program, I would like to thank first of all the faculty, those who have stayed back. Dr. Susovan, Dr. Pankaj, Dr. Vivek, Anjali ma'am, Dr. Musa. Thank you all for staying back and for your patience. We do understand, but as you could see, people are passionate about what they want to talk about. It's difficult to control them. But as we come to the conclusion, I would like to invite Dr. Bharat, organizing secretary with me from Intervention Radiology. We would like to thank all of you, especially our mentors, Dr. Sudhir Rawal, Dr. Amitabh from Urology, and Dr. Puri from Intervention Radiology, who have given us this opportunity to organize this event. We all know that focal therapy is in its infancy, and definitely it would be difficult to convince because there is a lot of inertia. But as I said at the starting address, that we have to find where it fits best for our patient. All modalities, we have a gamut of modalities. All modalities will serve our patient, but it is on us that we choose the best modality for our patients and deliver the best outcome. So with this, the whole conference would not have been possible without the support of our my team. Especially, I would like to thank Dr. Leela and Hia, who have been here comparing for us. They have been very supportive. I would like to call upon stage now my team. Ranju ji, can you please come on stage? Ratika ji, please come on stage, and Anju ji, please come on the dais. It would have been impossible without the support of all three of my staff. Anju ji is very tired. Please come on stage. We have been working tirelessly for the past few months to make this event a success. Despite minor glitches, I think overall we did well. Please, I would request you all to please give them a big round of applause. We had planned a felicitation, however, I think we'll do it in the department. But words are less for them for the amount of work they have put in. Thank you so much to each and every one of you. Hip hip hooray! Hip hip hooray! Hip hip hooray! Thank you. Can I invite all the members of the organizing committee to please come on stage, and the dignitaries on the stage? We'll have, yes, all of us can come on stage for a group photo. We are the last one standing, so this has to be. हो जाएगा. Some people can stand in front and the others can join. I think I missed Dr. Rohit Kaushal.
I think Ashish has thanked everyone, but I would like to tell you the man behind this event is Dr. Ashish. He has worked very hard. After actually we decided that we will hold this conference, he became father. And he used to tell me, sir, मैं तो कुछ नहीं कर पा रहा हूँ, ना मैं बेटी को time दे पा रहा हूँ, इतना काम है. So he is the man actually. So he has worked really hard. So and rest of the people, I second that.
And just to share with you all, attending इसको पीछे करके आप इनको डिस्टेंस चाहिए से तो I would request the entire team of Horizon and our IT guys, please. Pankaj.
Sponsors also.
Yeah. Please, Nishant. Gitika ji, please join us. Ekta madam, if you are there, please. Daud, Umang, Nishant, Ekta ji, Gitika ji, please. They have been such an integral component of our event organizers. They have worked tirelessly. They have not slept for the past 2 days. They've ensured that every faculty reaches here on time. It wouldn't have been possible without them. Thank you so much. Thank you. Thank you. Thank you. Thank you.